Thank you so much for joining us for this episode of Focusing on You. I'm Heather King with Hope Abounds, the Educational Director, and I'm very excited to have Dr. Mariam Sauer, who is a gastroenterologist with Wilmington Gastroenterology, joining us today. So thank you, Dr. Sauer, for joining us.
Thank you, Heather.
March is Colon Cancer Awareness Month, and Hope Abounds obviously focuses on all types of cancer for both men, women, and children. But I'd like just for you to share a little bit today from a gastroenterologist perspective, what do you do? Because obviously you don't just focus on cancer. So let's just talk about when a patient could potentially schedule an appointment with you. What would you see? How would you help those patients?
Well, gastroenterology is a very wide field. We have a lot of different organ systems within our field. We treat conditions in the esophagus, which is the food pipe, the stomach, the small intestine, the colon, the pancreas, the liver, the gallbladder, and really a lot of different things in the abdomen itself. So we see a lot of different conditions. We see benign conditions such as heartburn or reflux, and then we see a lot of other conditions that are more serious, like cancers. For any of these conditions, there are a wide variety of symptoms. So anybody that has any GI symptoms that are persistent, that are not necessarily managed or treated with medications or with their primary care physician, that's when they should really think about seeing a gastroenterologist.
Perfect.
And it's not only symptoms. We see a lot of patients that get to a certain age that need to see a gastroenterologist for their cancer screening. And as you mentioned, March is Colon Cancer Awareness Month, and colon cancer is one of the more common cancers that we have in the United States. It's the second leading cause of cancer death in the United States. So we actually see a lot of patients that have no symptoms. They have just come to us for their colon cancer screening.
Wow. So the second leading cause of cancer death right now, why do you think that is, when it is something that if people actually came for appropriate screenings might not be the outcome?
That's right. Well, that's an interesting question because colon cancer is one of the most preventable cancers in the United States. And the reason that colon cancer is still high in incidence is because people don't come for their screenings. Whenever somebody becomes 50 years old, everybody should have screening when they become 50 years old. If you have a family history of colon cancer or colon polyps in a first or second degree relative, we usually start earlier, about 10 years earlier than your family member was diagnosed, or at the age of 40, whichever comes first. However, many people don't know these guidelines. Many people get busy with life, they get busy with their families, and they don't realize that they need to come for colon cancer screening. And that really is the reason why colon cancer is so prevalent in the United States these days. We have a lot of different methods for colon cancer screening. We have a lot of different ways to screen effectively. And if you come for your colon cancer screening, really colon cancer is preventable these days.
That's wonderful. And so you said first and second degree relatives, just to kind of review that would be siblings as well as children and maybe parents as well.
That's right. So it's any first degree relative, but it has to be a first degree relative who has developed colon cancer or colon polyps less than the age of 60 years old.
Okay.
If you have a parent that developed colon cancer at 80 years old, we don't really consider that a genetic syndrome. We consider that more a sporadic cancer, something that has to do with aging and not necessarily related to genetics.
Sure.
So if you have a first degree relative, a mom, dad, brothers, sisters, or children who have had colon cancer or colon polyps before the age of 60, you should start 10 years before they were diagnosed or at 40 years old, whichever comes first. Second degree relatives also are only pertinent less than the age of 60. However, they're a little bit more remote to your family history, so you need 2 second degree relatives to really consider that as family history. For example, if you just have one uncle that had had colon cancer, that doesn't really count for you. It's not pertinent to your family history from a colon cancer standpoint. And if you're unsure about your family history or you're really unsure when you should start colon cancer screening, discuss it with your regular doctor. Or even yet, you can call a gastroenterology office, like you could call my office, and we can tell you, even if we've never met you, you are not a patient of ours, you do not have a symptom, we can tell you when you should start your colon cancer screening. We get those phone calls every day, and we're happy to advise people on that.
That's great. So your staff's prepared to answer that question, even if they're not specifically a patient of yours at the time when they make the phone call.
Yes, that's exactly right.
That's wonderful. So colon cancer screening. obviously some people have a fear of what that might look like, feel like, etc., which is probably part of the hesitation as to
Yes.
why they're not coming in and scheduling it. I mean, everybody's life is busy. I know you're a parent, I'm a parent. We have a lot going on and we both work, but sometimes it's just the fear of the unknown.
Right.
So from a patient perspective, what does that the prep look like,
Yes.
the actual procedure, and then afterwards
Yes,
as well?
yes. That's a great question. So there are many ways to screen for colon cancer. As you have alluded to, colonoscopy is still our gold standard for screening for colon cancer. And the reason is because colonoscopy is a direct visualization of the colon, and it allows us not only to detect cancers, which really, our goal is to detect these precancers, which are polyps, so these precancerous polyps. So not only are we able to detect them, we are able to remove them at the same time. It is one of the only screening procedures that we have for cancers where you're not only able to look, but you're able to do things at the same time. There are also other ways to screen for colon cancer. We have stool-based tests now. We also have blood tests that may be coming out in the future. We have that in the research pipelines right now. Not quite commercially available yet, but we definitely have stool tests. But colonoscopy is still the gold standard right now in the United States. Colonoscopy, actually the worst part about that procedure is the day before. It's the prep. You do have to drink a lot of things to clean out your colon. It's just a lot of liquid, and you do have to alter your diet the day before. The day of the procedure is actually super easy. You get sedation for the procedure, so you are completely asleep. You do not know a single thing about it. And during the procedure, we go in through the bottom with the camera. We look at the entire colon. If you have polyps, we are able to remove them at that time. If you have biopsies that need to be taken, we can do that at the same time. So we have the ability to do a lot of different things depending on what we find. The recovery for that procedure is actually quite short. You're awake, talking, walking before you leave us in the recovery center. That day is a day of rest. However, the next day you're back to your normal self and your normal life.
A normal diet.
A normal diet and everything else. That's exactly right. So overall, it's a very short period of time that it takes to prepare for that. And thinking about colon cancer as being the second leading cause of death in the United States, it is an investment. And colonoscopies do not have to be performed that often. If you have a normal colonoscopy, you have no family history, it's actually every 10 years. If you have polyps, it may be every 5 years. So it's not something that you have to do every year or even every 2 years. It's actually pretty infrequent.
Sure. And I know, from a breast perspective, a lot of women don't like to go in to get mammograms because they say that it hurts and it's uncomfortable and that sort of thing. But a colonoscopy for many women is even less frequent than what a mammogram frequency would be, or what the protocol is for that. So you did talk a little bit about polyps, and just to kind of define what that is. So when you're actually going in and looking at the colon itself, can you kind of just explain a little bit about what it looks like, what a polyp truly is, and a little bit about precancerous versus
like benign, so polyps are growth along the colon lining. It's kind of like having a mole on your skin. It's the same thing on the lining of the colon, and almost all colon cancers develop from colon polyps, the precancerous type of colon polyps. Colon polyps can vary in size, they can vary in shape, but we are able to directly visualize those at the time of a colonoscopy, and we do remove all colon polyps that we see. All of those polyps get tested to see if they are the precancerous kind of polyp or they are the benign kind of polyp. And depending on that testing, we know what kind of follow-up the patient will need. Colonoscopy is very good because it's a direct visualization. If you have something there, especially a big polyp, the chances of us seeing that is very, very good. It's not 100%. We can't miss smaller things. No test is 100%. But out of all the tests that we have for colon screening, that is the most likely to detect these precancerous polyps that grow into these colon cancers.
No, and that's very helpful. So in the past, we have interviewed Dr. McKinney, which is a pathologist.
Yes.
So when you remove those polyps would go to pathology, whether
That's exactly
it's
right.
the hospital or somewhere else, and then they report back to you on what they see.
Yes, that's right. We review that pathology and we compare that to what we saw at colonoscopy. We take the family history into consideration, the patient's history into consideration, and then we make a recommendation for every single patient on when their next colonoscopy should be.
Wonderful. And that's very specific, as you said, to every single patient.
Yes.
So it just depends on what you find when you're actually doing the procedure, what the pathology comes back, and also with family history
Yes.
and some other conditions that the patients have, correct?
Yes, that's exactly right.
Right. So, I mean, in any gastroenterologist or the majority of gastroenterologists would have the same sort of protocol. So, people watching this in other states and potentially other countries, it's the same sort of process and protocol, correct?
Yes, that's exactly right. Yes, we, as a GI community, we have tried to standardize our colon cancer screening methods and guidelines, and they are standardized for the United States.
Wonderful. And, we've from interviewing other physicians, different specialties. Everybody has guidelines. Everybody follows certain procedures and protocols. From a gastroenterology perspective, is there a certain set of guidelines that you use or look to more frequently? Not just for cancer, if you want to focus, on the colon cancer, but just in general.
Yeah, so we have several governing bodies for GI. And we take guidelines from those two institutions, the American Gastroenterological Association and the American College of Gastroenterology. However, especially for cancers, we also have the American College of Oncology. We come up with guidelines together, and we look at all of those guidelines. Actually, interestingly, the GI societies for a long time have said that we should change the age of colon cancer screening, not from 50, but to 45, because we noticed that the incidence of colorectal cancer was increasing in this younger population. Just this last year, the American College of Oncology actually came out with the same guideline and said, actually, everybody in the United States should start screening at 45 years old. Although this is the recommendation from the medical community, unfortunately, the insurance companies have not caught up with this.
Right.
So right now in the United States, there are no insurance companies I know of that are actually covering screening colonoscopy at 45 years old. However, we do hope through our societies to be able to change that. We're really trying to educate the insurance companies about this change in colon cancer screening. So it could be that over the next year or two that we'll really see that coming through, and that we will be able to screen as the medical guidelines suggest.
Well, that's wonderful. And sometimes we've talked about in the past that it is difficult. Insurance doesn't always catch up as quickly as to what science and all the studies show should be done. And from a patient's perspective, there's a lot going on. And so if it's not covered, a covered service, it is a challenge sometimes to get it done.
No, it is very much a challenge. Right now, if you're 50 years or older, there's no problem. It goes into your screening, your health maintenance screening. There's never an issue with that. It's just if it gets to be if you're a little bit younger, don't come into those guidelines. However, each gastroenterology office has people that work on this, that work with patients and work with patients' insurance companies to know exactly what that is before you get into your screening process.
Perfect. And honestly, as you said, it can save your life. So it's just very important to make sure that that's taken care of, whether or not it's a little bit out of pocket for patients.
Yes, no, that's exactly right. And I can't also stress the importance of, we've been talking about guidelines, we've been talking about age. No matter what age you are, even if you've had a colonoscopy, if you start to have GI symptoms, even if you're 20 years old, 30 years old, 70 years old, if you start to have GI symptoms that are persistent, you really should see a gastroenterologist. Do not ignore symptoms. We see a lot of patients that have had symptoms for a while, ignore them, and they come in for a procedure and they end up having a cancer. So even though we talk about guidelines, not everybody fits into those guidelines, and know that there are people that get cancer outside of these guidelines, ages, young ages. I had a 20-year-old the other day that had colon cancer. And nobody really thinks about young people as getting cancer, but that's the sneaky thing about colon cancer, especially rectal cancer. The incidence of that is really increasing in these younger populations.
So when you say symptoms, what specific symptoms should patients be thinking about, or if they experience that they should seek help?
So the most common symptoms are a change in bowel habits. It can be constipation, it can be diarrhea, but a definitive change in your bowel habit is concerning. Bleeding, rectal bleeding is also very common. Abdominal pain, weight loss. Those are the more common symptoms that we see, and it does not have to be all those symptoms. It can be one of those symptoms. Now, everybody can have a little bit of rectal bleeding here and there, but if it is something that is new for you, that is persistent for you, that has no triggers, definitely that is a time to see your regular doctor or a GI doctor. Do not ignore those symptoms, no matter what age you are.
Sure. So the normal path, most patients would probably go to their internal medicine or family practice doctor, and then eventually end up with y'all, right?
Yes, yes, that's exactly right. Although we do get quite a few self-referrals. Some people who really know their health care know, well, I should probably see a gastroenterologist. I might need to have a procedure to evaluate that. So we do get quite a bit of self-referrals as well.
Perfect. So say someone is diagnosed. So, you go ahead and you do the procedure, you find a polyp, you send it to pathology, it comes back that it's not benign, it actually is cancer. From there, what is the path for a patient?
So from there, we do something called staging. It means we try to find out where exactly is your colon cancer. Is it just in your colon? Is it in your lymph nodes? Has it spread to other organs? And depending on the staging, that dictates the treatment. So that patient will go on to have blood work. They will go on to have a CT scan, which is just a picture of the abdomen. It's an imaging study of the abdomen. It allows us to look at these other organs where colon cancer likes to go to.
Sure.
And from there, they will actually be set up with an oncologist, which is a cancer doctor, which will review all of that and determine exactly what they need. All patients with colon cancer get a surgery to remove that cancer, and depending on the staging, sometimes patients will also need chemotherapy. The good news is that colon cancer is one of the more treatable cancers that we see, especially if caught in the early stages. So some patients can be cured just with surgery alone. They won't need chemotherapy or really anything else. All patients with colon cancer will be in a surveillance program with colonoscopies, with blood work, with CT scans, going out at least 5 years. And really the oncologist or the cancer doctor will be the one that monitors that and determines if they need anything else past that.
Sure. No, that makes sense. And as we talked about before, it's very individualized. So
Yes.
it depends on how much cancer that you find. Now, are you performing that surgery or is someone else performing that surgery? When do you bring someone other than just oncology in?
Yes, so it's a general surgeon usually or colorectal surgeon that performs those surgeries. We have several in Wilmington and in our surrounding areas. We bring those surgeons on pretty early, but they will not do anything. They also want to wait for the staging to come back to determine if anything else needs to be done. But we do try to get patients set up earlier just to meet the physicians that are going to be part of their care team.
And you did say that colonoscopies will continue
Yes.
after that because
Yes.
the majority of patients don't have the whole colon removed.
That's
it's just
correct.
a section.
That's
and
correct.
how long is the colon if we stretched
It's 3
it
feet
out?
long.
So
It's 3 feet
so
long.
that's big.
So it is big. And with a colorectal cancer, usually you have half of your colon removed. We try to leave some of your colon in. So you do for the rest of your life need that rest of your colon surveyed.
So what is the reason for leaving part of the colon in?
Really for quality of life. You don't need your colon. It is actually not an essential organ. You can have your entire colon removed. However, you will have some symptoms, increased bowel frequency, some urgency, things like that. Not to say that that's not manageable. We have many patients that do have their entire colon removed for various reasons, not just cancers. But you are more likely to have a better quality of life if we are able to save some of your colon.
Sure, absolutely. And that makes sense. So even if a patient has part of their colon, their body can function normally as if that other part was not removed.
That's exactly right. Yeah, most patients will notice some changes, like maybe changes in bowel habits, but very mild. And some patients may not notice anything from having half of their colon removed.
So technically, from a quality of life perspective, if they're screened early, if you catch it, if you're able to get them to surgery and go ahead and get the cancer out, from a quality of life perspective, they can be a survivor and still have a great quality of life.
Exactly.
Yeah.
That's exactly right.
Which isn't the case for every cancer.
That's right. And that's why I say colon cancer is one of the more treatable cancers. It is definitely a preventable cancer with colonoscopy because, like I said, our whole goal is not to catch a colon cancer. When I do a colonoscopy and I see a colon cancer, it really breaks my heart because I know if that patient had been there 5 years before, 2 years before, we may be having a different discussion because at that point it would have just been a precancerous polyp. And those we are very good at being able to remove.
Absolutely. So from a GI perspective, whether it's in the colon cancer area or any of the cancers, have there been any new developments that have really changed some of the way that you're treating patients and their care?
Yes. Well, in terms of colon cancer, like I said, our biggest push is to do non-invasive screening, the stool-based test and blood-based test. The stool-based tests are available, however, they're still not first line, and then the blood tests are very promising, but they're still in the research phases. We are also working a lot on improving preps. So all of that liquid that you have to drink before you have a colonoscopy, we are trying to make that more palatable and trying to make that a better experience for patients. So we have a lot of research studies going into that as well. I would say the biggest advance that we've had in GI is actually with the liver, with hepatitis C. Hepatitis C is actually something that is a chronic condition in the United States. It leads to liver cancers. So we see a lot of liver cancers in the United States that are related to this virus called hepatitis C. Baby boomers are particularly susceptible to this. Most patients with hepatitis C do not even know that they have it. It does not cause a lot of symptoms. Sometimes it does not even cause its elevations in your liver test, or they may be mild to the point where your doctor may not even notice it. But hepatitis C, over the last several years, we've had a big breakthrough in medical treatment for it, where now it is curable through medication.
Wow.
And in the past, it was a chronic condition that we really couldn't cure.
Wow. So from a patient's perspective, liver cancer, what is that prognosis? And
Yeah.
does it depend on when it is found?
It does. It depends on when it's found. It depends on why you have it. Again, it depends on the staging. Has it spread? Is it
Sure.
involving anything else? But it is not as good a prognosis as, let's say, colon cancer. It's very variable, really treated by our tertiary care centers in North Carolina, Chapel Hill and Duke. You really need a subspecialty center to treat that. It's a little bit harder to treat. The current guidelines for hepatitis C screening, the CDC actually realized we have a lot of people in the United States that have hepatitis C that puts them at risk for cirrhosis and liver cancer. So they came out many years ago with general screening guidelines. So this is another screening guideline. If you were born between the years of 1945 and 1965, it doesn't matter if you have any symptoms or anything, you need to be screened for hepatitis C. It is blood work. It is very easy to do. Primary care physicians do it, GI doctors do it, but that is also a screening recommendation for everybody.
Wow. So if that's done, and do most primary care, family practice doctors include that in what they're doing for, a normal physical
Absolutely.
and wellness type
yes,
thing?
it should be. Yeah, absolutely.
And then if anything is found, then they would be
Then they
sent.
refer them to us. Yes, that's exactly right. And then we can kind of stage their hepatitis C and then figure out what kind of treatment plan they need.
And that's when potential academic centers are pulled into the situation.
That's exactly right. Yeah, if a cancer is found. Not everybody with hepatitis C has a cancer, but it is a risk factor for that.
Sure. So we talked a little bit about some of the other organs that GIs deal with, which when you listed them, I was like, wow, that's a lot. And I know pancreatic
Yes.
is one of those cancers.
Yes.
Pancreatic cancer is associated with multiple hereditary syndromes.
Yes, that's true.
And we talked a little bit about family history.
Yes.
And in the past, we've done some different educational programs kind of on knowing your family history and what that could mean. Do you want to specifically share a little bit about Lynch syndrome, how that kind of fits into what you as a gastroenterologist do, and how it would affect patients and their families?
Sure. So there are many genetic syndromes that affect the GI tract, and they come in a variety of forms. Like you mentioned, Lynch syndrome is one. We have a lot of polyposis syndromes, which this just means patients have a lot of polyps. Most often, this is actually found during colonoscopy. We find it if we have a young patient that has polyps, that has a lot of polyps, especially if they have a family history of cancers, it really makes us think, is there something in their genes that's causing them to have these polyps or even cancers? Sometimes we find it on pathology. When you were saying pathology, we send these polyps off for testing. Sometimes things in pathology make us think about this. But usually we think about it in younger people that have numerous polyps over a lifetime. And if we think that somebody has this, it's actually very easy to test for. We send them to genetic counseling. So genetic counselors will sit down, go over their family tree, and we have lots of genetic testing, which is essentially just blood work. We are able to test for a handful of different genetic syndromes we know that can involve the colon, but can also involve different organs, like you were saying, the pancreas, and different organs that can be involved. The reason we care about this is because if you have a cancer that is caused by a genetic syndrome, we follow you completely differently. We know that you are increased risk because of your genetics. So those patients actually can have colonoscopies every 1 year, like patients with the Lynch syndrome, like you were talking about.
Sure.
Lynch syndrome is just a polyp syndrome that puts you at increased risk for colon polyps and other cancers throughout the body. So those patients actually go on to have colonoscopies every 1 to 2 years. And it's even more important for their family members because it can be inherited. So actually their family members will get testing for that as well.
Yep, and it's, as you said, the frequency is increased, but that's because the actual polyps form from that precancerous that you
Right.
talked about into something more severe.
Right, they don't follow a
quicker, right?
normal pathway.
Right.
So in an average person, it takes about 10 years to develop a polyp, to develop into a precancerous polyp, then to develop into a colon cancer. If you have something in your genes that's causing you to develop these, if you have a genetic syndrome, you don't follow that pathway.
Right.
You maybe 1 year have nothing in your colon, and the next year have a colon cancer. It really can be that sudden. So those patients need heightened surveillance, as do their family members if they have that same genetic syndrome.
Absolutely.
And there are some genetic syndromes that have a 50% penetrance, meaning your kids or your offspring have a 50% chance of having that genetic syndrome. So it's pretty high chances, and that's why it's really important to identify those patients and to test those patients. And really that burden is on the physician. We always try to educate other physicians about being cognizant of patients that have a family history. Unfortunately, not everybody knows their family history, like you were saying.
Sure.
And it is important to try to know your family history because that's really where we catch it, is within these family histories. And then knowing that younger patients that get precancerous things or cancers really need to be tested.
And you know, some people don't like to talk about cancer,
Yes.
especially something where they feel like it's in their colon. You know, there's certain cancers where, you know, we have pink ribbon everything,
Yes.
and breast cancer is, you always see billboards and a big fight, and colon cancer, we really don't have a national spokesperson
Right.
that says,
Yes.
you know, blue ribbon everything.
Yes.
So I think that there sometimes is a stigma associated with certain cancers, and I think that anytime you get in this GI area that people are a little more private about it.
Yeah, that's definitely true. And we are trying to change that. We have a lot of
Absolutely.
educational campaigns out there. Our societies do that, especially in March, which is Colon Cancer Awareness Month. So we are trying to change that.
But there's nothing that a patient does that's wrong as to why
No.
they get cancer.
Yes.
And I think that's one of the biggest things that some people think, well, gosh, is it something I did? Did I eat something
Right.
wrong? You know, and yes, it's their bum, but
Yes.
everyone has one,
Yes, that's
and
exactly
we
right.
just have to take responsibility for our own health care.
Right. That's exactly right. That's exactly right. And I tell people all the time, the biggest risk factor for colon cancer is aging, and there's nothing you can do
Right.
about that.
No, unfortunately.
Yes, that's right.
We're all getting older.
That's right.
And as you said, a lot of people, or not everyone, but quite a few people will develop some of these GI cancers later in life, but that's just part of a natural aging process.
Yes.
It's all cancers.
Yes.
It's not just GI, but as people get older, in their 80s, sometimes 70s, they develop cancer, and that's more of a normal aging process.
That's exactly right. Yes, that doesn't mean that has anything to do with your genetics. That is just part of normal aging. As you get older, you can develop cancers.
Right. Our body just starts breaking down a little bit.
Yes, unfortunately.
Is there an age where you stop doing colonoscopies or stop
Yes.
screening?
Yeah, that's a great question. So this has changed over time as we are becoming healthier in the United States. We're living longer. We're taking better care of ourselves. So currently, between the ages of 75 and 85, we look at your overall health. If you remain healthy, you should stay within our screening program. If you develop any major medical problems, then obviously you don't have to keep with your screening, your routine colonoscopies.
Sure. No, and comorbid issues.
Right.
So if they have heart disease and overall
Right.
health is substantially
Right.
not as optimal as it
Yes,
should be.
And that can be at any age. You can
Sure.
be 60 years old, but if you have a massive heart attack, a big stroke, or something like that, we're not going to keep you in our screening program because you have to be able to participate in that program. You have to be able to undergo a procedure, have a prep, and those things. So we do. We look at everybody individually. But for the vast majority of the people, if you get to 75, then we just kind of follow you along and see how you do. And if you remain healthy, then you come in for your colonoscopies. I I had an 85-year-old come in for his colonoscopy today. He has no medical problems. He's on no medications. And I told him, unfortunately, your good health is going to keep you seeing me forever.
Well, that's great that he's 85 and
Yes.
everything is perfect. I hope
Yes.
I'm like that when I'm 85 too. But, well, is there anything else additionally that from this is a patient educational video, so anything from a patient perspective that you really want patients to really know about?
Yes. I would say, to add to what you said before, that a lot of people are embarrassed by GI symptoms, especially if it's lower GI symptoms, bowel habit changes, rectal bleeding, hemorrhoids, things like this. I can guarantee you that half the people in your neighborhood have similar issues. Do not be embarrassed by that. Do not put off seeing a doctor because of that. That's probably what I see most, is that people have had symptoms for a while. They're embarrassed to come in because they think it's only them that's having those symptoms.
Right.
And I can guarantee you that your neighbor has it next door. Come in and see us. Do not ignore your symptoms.
No, and that's great advice. And, Dr. Sauer, thank you so much for taking the time
no
to
problem.
talk to all of us today, and thank all of you for being here and participating with this. And, please continue to review this video if you have any questions on gastroenterology and colon cancer. And there are many other videos on the Hope Abounds website that are available for you to review as well. So thank you so much. Have a great day.
Thank you.